How y'all doing? My name is Dennis Boyle. I'm a rheumatologist. I'm from Denver, and I work at a company called COPIC, and we're bringing you this presentation today. This is really is something that's my passion. I've done a lot of different things in medicine, but the thing I'm proudest of, I think, is that I spent 10 years running the program for the medical students teaching communication stuff. So this is really about communication. This is some of this real, it's fun stuff. And it really is worthwhile taking another look at it, even though we all do this all day, all the time. I also work at COPIC, which ensures the clinic. And just a quick pitch is, I'm a risk manager. There's about 5 of us now, and we're on call 24/7. So if you're in the ER at midnight and you have a tough case and you're not quite sure what to do risk management-wise, we're not the only available thing you have, but we are available for that and trying to help you out. So let's get started. We're going to start with a communication video, and I want you to pay close attention to what techniques you see in this video. There's no audio, Steve. It honestly worked seconds ago, so. Huh? Yeah. Wow. There we go. One more time.
It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me, and I can just feel it, like literally feel it in my head, and it's relentless, and I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there...
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
See, I don't think that is what you need. I think what you need is to get the nail
See,
out.
you're not even listening now.
Okay, fine. I will listen. Fine.
It's just... Sometimes it's like there's this achy... I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
That sounds really hard.
Thanks. Thank you. Ow!
Oh, come on. If you would just...
Don't...
Try to see things.
So, we're just trying to set the tone here. So this will be very serious, but I do want you to be thinking about this in terms of techniques, and also we're going to have some fun. So, what technique did you notice in that video? Unfortunately, I have to run it up from up here because I guess is there a dead zone down there? Is that where Stephen King has his? Okay. Well, why do you leave me down there then? I don't know. So, what did you notice there? Did anybody notice the technique that this guy used? Anyone? So. Empathy. So, and what was the technique part? That is what you saw. He did some empathy. So, but how did he do empathy? What did he do? He listened. How did he listen? What did you say? Actively. So he did something called, thank you for trying. So he did something called active listening. And that's how he built this communication. So, and then, I don't know, do we have a neurosurgeon here? What do you do with a nail? I don't, so it's not, we're not really sure. So what's the thing about this is that communication is a technique. And we all communicate all the time. We've been communicating since we were babies. We some of us say 10,000, women say 10,000 words a day. Is that what I've read? And men say about 6,000 words a day. So there's a whole story behind that. So, but we communicate all day long. We say words. We listen. We do this non-verbally. This is stuff that can be learned. You've done this over and over again, and because of this, you're a great communicator, right? Are all you all great communicators? No, I mean, because you've done it, doesn't, so this is the Anders, there's a wonderful book, Malcolm Gladwell, about the 10,000 hours to get mastery. That comes from a fellow by the name of Anders Ericsson. And the whole point of what Anders wrote is, if you do something over and over again, you can get good at it if you're paying attention and you're working at it and you're building skills around it. So we all can improve this all the time. How many patient interviews are you going to have in your lifetime? What do you think? Thousands? 150,000 is the best estimate for a primary care doc, 40 years, 45 weeks a year or something like that. So it's a large number, but doing it over again doesn't necessarily mean you do it great. So, all right, we're going to learn some techniques. And the point of this is that when you go into clinic this afternoon, hopefully there'll be one thing you're going to do a little different. I'm going to throw a bunch of stuff out, and I just want you to say, maybe I'll try that. I haven't done that before. So why do you think communication matters? Why is it important? Yes?
Maybe the nugget that actually points you to what the problem is.
So the communication allows you to get the problem. What percent of your history, what percent of your diagnoses are made by the history alone? So it's about 85 to 90% is the number. You guys all have that right. So it's really the way you get, good communication is the way you really make your diagnosis. Now, obviously, there's other things that can help you with the diagnosis, the abnormal EKG, the creatinine of 10, for Steve there. So, all of those things. But so what else? Beside a better history and, getting a better diagnosis, what are the other reasons it's important? Big hint here, I work for a company that insures physicians in clinics.
Less likely to be sued.
Less likely to be sued. And what percent of lawsuits have communication as the basis of it?
75%.
That's about right. Good guess. You did well. Yeah, so yes, the number is, we do this at COPIC, and my best guess is about 2/3, so, really close. And we look at 100 lawsuits, and about 2/3 of them, I'd say, I'm very happy I wasn't working that day. That person didn't do anything wrong. There's there's about 1/3 of them where you say, wow, it wasn't good care. So a lot of it is around, anger and not feeling happy with you. Anything else? So we got a little malpractice stuff, a little better history. Say what? Compliance or adherence. What percent of people take the meds that you give them? Beside Percocet. Percocet's 106%, I think is the number, but no. What percent of people take those meds you give them? What do you think? 30? 60. So it actually 30 and 60 are both correct. So isn't that great? So 1/3 of people take pills the way you give them, exactly the way you give them. 1/3 of people sort of take pills, as in, doc, I had that bronchitis, and I took the rest of the Zithromax you gave me, but I want some more Zithromax. So you were supposed to take all the Zithromax last time, right? So 1/3 of people take some of the medicine some of the time. And 1/3 of people don't even fill our scripts. So wonderful study from Kaiser where they actually got rid of all barriers. You're on the 3rd floor, you're the doc. You electronically send the script to the 1st floor clinic. The patient walks out, says, Dennis, you there? Here's your meds. Any questions? No copay. Meds are ready when you get down there. 60% of people pick the meds up in that situation. So amazing. What else? So we got the meds. How about patient satisfaction? Does anybody care about that? Is McFarland checking? Go ahead. What are you saying?
Yeah, it's very important.
It's very important. And do you all get measured on that? Yeah, so I actually worked at the county hospital, and for a while they were actually paying us about, more or less depending on what our patient SAT scores was. So we'll see. I think that's going to be coming as we go down the pike. Or mostly, I think they'll be paying us less if we don't do well. I'm not sure that you get paid. You know how that goes in the world. Better story. Healing, I think, is important. And I think personal satisfaction. One of the things that I've learned about this is understanding what happens. And that's one of the reasons I got into this, is not really understanding what happens in the room. So 3 quick interviews here, or these are called trigger videos. These have a rheumatology bent, but I think that can occur in anyone's practice. So the question is, you're seeing 3 people in a row this afternoon. Which of these is the one you least want to see? So.
Man, I tore my knee up in high school playing football, and I just got ready for a knee replacement, you know? And the knee kills me most of the time now. Started out taking about 4 Percocet a day, and that wasn't doing the trick, and worked up to about 8 a day, and that still wasn't doing it. And then finally, I was opening the bottle over the toilet, and I spilled all the Percocet in it, John. I mean, I really need my medicine, you know? This thing is killing me. I don't understand why you're being so hesitant.
Doctor, I saw you about a month ago, and you said that this was only fibromyalgia. Well, ever since then, I have had blurry vision, I have had more headaches, and I have had more neck pain. I also looked on the internet, and I am convinced that this is multiple sclerosis. Now, I demand to see a neurologist, and I want an immediate MRI.
It's getting better. It's a bad afternoon.
I knew it. So it is cancer. I knew something was wrong. Every day I would have checked the lump and worry about it. My husband said not to worry, that you have checked it out and I was fine. But I just sensed something was really wrong.
So 3 patients you're going to see right in a row here. One of them is interested in some oxycodone for his knee, or a little more oxycodone, I think. The second one is a little bit angry about the diagnosis and the last time you saw them. And the third one is sad. So which one is the hardest for you? Not Chicago, so you only vote once, right? So who thinks that the drug seeker, or the person interested in drug is the person that they least like to see? Okay. It's a handful. Okay. How about the angry person? A fair number. And then how about sad? Okay. So it looks like the angry one is the winner, which you typically see. But but all y'all voted for different stuff, right? So what did we just learn from this? Here are my 3 favorite physicians. What did we learn from that?
Everybody's different.
Everybody is different. Who said that? Yeah. Why do you think that? Why do you think that is?
Because everybody's different.
Yeah. No, that's a good. No, and I think that's one of the key teaching points is with this. There's a couple. One of them is this depends on your past experiences. So the toughest patient for me is that middle one, the angry person, as it was for a lot of you. And I was running through an area in Denver with my best friend, who's a psychiatrist, and I was describing this interplay. This is years ago. And he said, do you realize that all your tough patients remind you of your mother? And so there is something to that. And I had a partner who had grown up in an abusive household, and he loved the angry guys. People would come in angry, and he said, "Oh, I'll take them all," and he would just love it because it was just like being at home, So he had grown up in this tough household with really sort of an angry dad. So it is different for different people, and it depends on your past experiences. And the other thing is, if you voted for angry when you have as much gray hair as I, you're still going to be struggling with the angry person. So it's different from one person to the next. It's past experiences, but your upset patients sort of will always be alike. So if anger is the one you don't like, or if it's sad, And your goal today is to say, the next time I see someone who's angry, somebody who's sad, whatever it is my, the one I don't want to see, I want you to have something in your toolkit that you didn't have before 12 o'clock. So that's sort of where we're going with this, right? But your up-pitch, remember that, that's actually the first teaching point is, if it's angry, then remember angry, and that's what you want to be working on. Medical interviews are different. So there's two axes when you're doing a communication. One of them is emotion. The other is getting information. And does anybody have teenage daughters? Okay. So I don't know if you're a teenage, I have a son. My son is like, where are you going out? What are you doing? Nothing. Who you going with? Friends. I get no communication. So actually, he would be just nowhere. But my daughter it's all, she's now not a teenager anymore, but it was all emotion. It was everything. What do you mean I can't do this? What do you mean I can't come home? It was high emotion. Actually, very little information ever got passed between the age of 16, and they do come out of it eventually. So, but well after college, I'd say so. And then on this end, I think of air traffic control. And I think of when Sully landed his plane on the Hudson, there was this wonderful tape they played on 60 Minutes. And he says, I'm going to go ahead and put the plane on the Hudson. And the air traffic control says, roger that, you're going to put the plane on the Hudson. So, okay. So getting information out without any emotion at all, right? But in medical interviews, we're like this, right? So, the discussion you could have with your next patient this afternoon could be, congratulations, you're pregnant, or I'm sorry, you're pregnant, right? And it could be somebody you don't know, right? So there's all these things so we have very high emotion. We got to get information, and getting the information is why we're always worried that we can't do this well. So most of the studies suggest there's about between 15 and 30% of difficult encounters in a practice. And so that comes to, if you're seeing 20 people a day, that's 3-4 patients where, things, you're not singing Kumbaya. So the other part of this, there's 80% or so that are great. So, I'm taking my lisinopril, my blood pressure's good, we come in, we sing Kumbaya, I'm happy, how's the kids, we go on. So those aren't the tough interviews. That's not the ones we're talking about. We're talking about the ones where there's this other stuff. So what makes these so tough? And it is a complaint-driven system. This is the Colorado Medical Board. You probably won't be getting notices from them, but it is, lawsuits and things are complaint-driven. And we mentioned this already, so we'll just do this quick. Communication issues are the leading cause of lawsuits. And what's interesting is this data. This really comes originally from the New England Journal. So that most errors don't cause lawsuits. So it's actually fascinating. So if you actually look at the data suggests that at a fairly good-sized hospital, one person a day leaves the hospital worse off because of their admission in your institution. So that's an average. That was UCLA and Harvard data. So that's from Mecca. So I think it's probably the same at most hospitals. So there are a lot of errors. Most of those don't become litigation. And then litigation, as I already pointed out, a lot of it has to do with people being mad, not necessarily making mistakes. So, and Wendy Levinson did a wonderful study on this, and we'll just say that she looked at people that hadn't been sued, and they basically spent about the same. They spent very little. They spent a little more time, but not much. But they were much more active in their listening, and they used some humor. Doc, I need some more Percocet. It's killing me. I can't get a knee replacement now. And I need some more meds. What do you say?
I'm an ENT, go to your ortho.
Okay. So, all right. We'll try. Primary care?
No, retinal specialist.
Retinal specialist. Come on. Primary care. Everybody's going to go like this, right? So, okay. Give it a shot. What do you say, Colette?
I'm a pediatrician.
Okay.
But I would say...
Yeah, that's okay. You can give it a shot.
Probably... well, let's talk about that. How much oxycodone are you using now? And and how long have you been doing that? And I would try and get some more information. Who's been prescribing that for you? And why are you here with me today?
Yeah, okay. So what's she doing there? What's the technique she's doing? Brenda, internal medicine. All right. What's she doing?
Listening to the patient, gathering more information.
Yeah, gathering more information. Right. So, and I think that's the first thing to do is, instead of reacting, right? Because this is easy to, and as you gather more information on this guy, he's a good guy. Knee replacement would cost him about $7,000 out of pocket, and he doesn't have it. So, and he's not doing well at work, but he's a plumber and he can't work with his pain. So as you get a little more history, which is Colette wanted to do, and you're helping. So open questions. So, how long does a patient have to talk? ENT understands this too, so you can't get out of this one, Joel. How long does a patient have?
11 seconds.
11 seconds, right? What do you guys think? Anyone? There's been 5 or 6 different. Go ahead.
As long as they're saying something that's relevant to their treatment, then I'll let it go on.
Well, okay, you might be better at it than everyone else. But what's the national average on this? So, 11. So there's without interruption.
11 seconds.
Yeah. So there's been a bunch of studies. It's been 22 seconds, 20 seconds, 18 seconds, 15 seconds, and 11 seconds. I mean, it's an easy study to do if you're taping interviews. So the average is somewhere in the 10 to 15 second range. So why does that happen? Why would you cut someone off?
A lot of times they try to make causation for something that's totally irrelevant
Uh-huh.
to what we're seeing.
And is that important to know or not?
Well, if it's not relative to their eye or diabetes or their hypertension, which affects the eye, if they're talking about their foot, then it probably would.
Okay. So that's an interesting point, and obviously you're a super specialist, but we still, there really is this, a lot of times there's what the patient thinks about what's going on. That is important, even if it doesn't relate to the foot. And we can do some examples on that. But I think mostly we're afraid that the person's going to just keep going on. What's the longest someone will talk? What's the real numbers on it? It's very interesting. It's about one. They taped 5,000 people, and 1% of them talked for a minute or more. So it's really a very low number that ramble on and on. Most people, if you say, "Tell me why you're here to," tell me. So as she was saying, she was suggesting, "Well, tell me more about this pain. What's going on?" And we're just afraid that we're going to go down the rabbit hole. And the very first thing to do is always start more open than closed. What's a closed question? Yeah. Do you see floaters? Yes or no? Right. And you can do that. Now, can you never ask that question? Am I saying never ever ask closed? No. You start open, and then you go close. So you do something we call the weave. So tell me about it. Tell me more. So you've had this pain for a while. So let me ask you some of the real specific stuff I need to know about this after you've done a few open questions. And it makes a huge difference, as to connecting with the person and getting a better story. Then you need to listen. What's said, and the most important part about listening is you can't be talking. So, and there's a lot of it's in the nonverbal. So the other thing is, even if this person is complaining about their foot pain, and they have an eye problem, and I'm very sure that it's going to be hard to make that connection. It's still, tell me more about it. Open up. So you're thinking that the foot has something to do with the eyes, and sometimes you'll find that there is. Although maybe what it is my feet are really numb. And I've had this diabetes for a long time, so maybe it is saying, geez, you've got a bad neuropathy. And it helps you because then at some point you can tell the person later it's not related to the foot. So, but you can't know that till you know what they're worried about. So the next thing is you need to recognize early that you're in with a person that's where this is going to be difficult. So let's say, did you say angry was one of the, yeah, didn't see? So how do you know you're seeing an angry person?
Just by their
Facial expressions, walking in the room. The biggest one's right in the middle there. Usually it's the MA who says, Dennis? Remember the last time you saw this? Yeah, okay. So have fun. Go ahead and make sure you do all that touchy-feely stuff you talk about. So, but if you leave the room and you haven't really addressed it, you often lose it. It's very hard to leave the room and then come back in and say, geez, Mary, that didn't go very well, let's reboot. You can try that, but it's hard. So recognizing it early and then using really open questions. So the very first key is we don't do that very often. Typically, we cut people off at 10 seconds, to 15 seconds. And we need to, and what happens is we then direct the story because we're so afraid they're going to go on and on and on. Although that doesn't really happen. We're afraid, and they don't tell us what they're really concerned about, which will be important. The other thing is to diagnose the relationship issue. And so this is Sigmund Freud in his famous couch. And the thought here is just to be thinking, this is sort of do we have a psychiatrist here? There's a meta thing about psychiatry, about being out here and really just looking at the relationship. This is what my psychiatrist friend you can probably tell me later whether I'm misquoting him or, but I think in this sense, what would I be saying about this guy? I would say after I've done open questions and he's gone on about, how he can't get his knee replaced and he's having a hard time working, it's that he really is worried about getting his pain controlled. And he's sort of, he thinks the way to go with it is getting more oxycodone, or a drug we call Percocet. So at least I try to do that as in addition to, first diagnosis is OA of the knee, second diagnosis is, whatever your problem list thing. I also try to do a little bit of a, what's going on relationship wise, and he, why is he doing that? So we got a toolkit. First thing in the toolkit is open questions. Make sure you're using open questions. And then secondly, thinking about diagnosing what's going on in the room with this patient when it's not going quite right. Why is this person angry? Why are they sad? What's going on? So this lady is angry. And we have an internist. So I am really, you said last time this was only fibromyalgia. And I'm really worried this is multiple sclerosis. And I demand you take care of this right away. So she hears what I'm saying. Okay. Tell me more about why you think that. So she's doing, what would you call that? What's the first thing I hear what you're saying? Is empathy listening? This is like an acknowledgement is what you'd call it probably, right? And, tell me more about it. So doing open questions. What else can you do? And people up here can't get away with this too much.
It looks like you're angry today. You're very angry today.
So she's actually going to she's going to talk about the elephant in the room. This person is angry. You think that's okay? Yeah, I think it is. I think identify that emotion. And why is it good to identify the emotion? Although sometimes and I want you to be thinking about this ahead of time, is the best word angry? Upset. I like upset more because I think, there's a little bit pejorative. Why might that really be a good thing to do a reflection statement? Seems like you're really upset.
Sometimes they start crying.
Yeah.
Something else is going on.
Yes. So what's underneath this anger? Fear. So that's the key point. Underneath anger often is fear. And so this is really not an awful person. And by the way, this is a person who's worried about having MS. Does the doctor ever have anything to do with what's going on? Does the doctor ever cause these kinds of things? No, never could be. What'd she say? Do you remember what she said? Last time I saw you, you said I had only had fibromyalgia. That was me that said that. So what's wrong with that? Only. Why? What's wrong? That's good. Fibro's good. It's not a bad disease. It's not like horrible. People don't die of it, right?
Belittles her experience.
Yes. So she feels terrible, and I'm belittling her experience. So in this case, I got a little bit of it on me that happened. So what's next in our toolkit? So we're open questions and diagnosing stuff. So there's two issues in any all the difficult encounters we showed. And that's that there's a big emotion. And what's the Wolverine have here? He's angry too, right? So, and then they also have different goals. So here's 2 goalposts. And I think that at the bottom of 90% of my tough encounters, I find this to be true, that there's a big emotion, the anger, the fear, the sadness stuff, and that there's a goal that's different. So what's the difference? Yes, please.
Going back just to your last comment about only have fibromyalgia.
Yeah.
What if the patient heard only, but the doctor didn't say only? The doctor would have likely not said only, but having to deal with the patient who believes that they heard only. And the doctor's probably likely going to say, what are we left with then? We have a doctor who tried to communicate effectively and a patient who maybe added their own.
Well, people bring their agenda into it. So, we have a psychiatrist here, so am I going to pick it? I think that's, in a sense, yes, I think that happens a fair bit. And then also, in a sense, I think it's legit. Your own experiences, that's because they're coming in with this concern. Do you have a thought? Or, yeah.
I think that's accurate and validating.
Yeah.
Their perception.
Yeah. Yeah, I think my answer would be, what you heard me say last time was it was only fibromyalgia. Well, if I said that, I apologize, I think of this a lot when watching debates. That sometimes if people just said, I made a mistake, it was a long time ago, I apologize, I'm sorry if but that's another story. So underneath anger is often the fear. That was your point that you made. And different goals. Here's a couple different goals for you. We already talked about oxycodone, but I got bad back, I want to get an MRI. Well, we're choosing wisely. We're not doing MRIs in everybody with, 1 week of low back pain, right? So that's a goal that's different. And we call this chief complaint, and then I went to azithromax again. We call this the chief complaint and chief concern. So 1/3 of the time, people have a chief concern that's completely different than a chief complaint. So that's why when you're investigating this foot thing, even though you're a retinologist, and that, the foot thing is what their concern is. And sometimes their concern is something that's, bogus as can be. Sometimes it's very real. I know someone that had bad cancer. Everyone with a headache thinks they have a brain tumor. And, you need to be able to address that. Now the gout has nothing to do with your retina problem. So, but maybe it does. Maybe the steroids you're taking is, making the retina worse, right? So that's the other, you take a lot of steroids for the gout, and so. By the way, so how many complaints does a patient have? What's the average for primary care? 3. 3 is a number. It's 2.7 according to Wendy Levinson again. So, and what happens? Anybody know what the doorway question is? Anybody ever had the doorway question? So this is by the way. And what's interesting about this is I did some teaching in Zimbabwe, and I talked to the MMeds in Zimbabwe. Had this very long discussion. So this is on the other side of the world, literally, and they knew all about what the doorway question. They actually knew exactly everything about the doorway question, and they even had a phrase for it and stuff. In their native, in Swahili, I think was their tongue. So, and what it means though is anytime that you've said you get to the doorway and you get to, oh, by the way, that means you didn't ask them about, is there anything else? So very early, you also want to be saying anything else before we dive into your eye. And you can, if they say my foot hurts, you can say, I can't help with that, but at least you know that it's there. So, a quick little video that's worth your time.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, Not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here. And you're not alone. Sympathy is, ooh, it's bad, no. You want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
So a beautiful video, Brene Brown, you can get it on YouTube, and it's worth watching a couple times. Oops, although not right away. And I think this is what we do all the time. I think the temptation is to say, this is what I do with rheumatoid arthritis. If I'm seeing you for your rheumatoid arthritis, my temptation, instead of saying, that must really be hard, my temptation is to say what? To say, oh, we got a great drug and we're going to get this completely better and we're going to have it all. I mean, your temptation as a retinologist is to say, oh, we're going to be able to fix that right away. Well, the first you may want to say, so what's it like not being able to see well? It must really be scary. Tell me about that, right? So just doing a little bit of what we call, and trying not to, we tend to, it's not to say that you should never say we have something I'm going to be able to get this all better. I'm not saying you don't say that, but you want to really first, if there's a big emotion, you want to let that run. So, and we tend to do this as surgeons. We tend to do this too. We're going to get this better. Okay, fine. But, right now I'm really scared that my kid has appendicitis, and that's really scary. No, it's appendicitis, and let mom dwell in the appendicitis. It's real stuff. So the way you do this is with something called reflective listening, similar to active listening. This fellow Gordon did parent effectiveness training in 1970, and he's the person that first described it. Now, I am sure Sigmund Freud was doing this, 100 years ago. This has been around a long time, but actually saying back what you heard someone say. So it's a little different than active listening, right? What's active listening? So I'm from Denver, so how about the Hawkeyes? What do you think? The quarterback's great. You're going to have a run game this year. They're going to be passing. So this was my sports discussions. I grew up in Philadelphia, talking about the Eagles back and forth, right? So that's active listening. Reflective listening is what? What's reflective listening for this woman who is afraid she has multiple sclerosis? What would it sound like? So you're really afraid you have multiple sclerosis. Sounds like you think you have multiple sclerosis. Sounds like you thought I said it was only fibro last time, right? So, and the signpost that I mentioned here is a word like sounds like. If you say sounds like, At the end of it, in every interview, you're basically always doing reflective listening, and that's what builds the empathy is because the patient really feels heard. So that's when Brene Brown's talking about. We really want to have empathy. The way you do that is by saying, "So it seems like you're really upset with this, and you're really concerned. This is MS. Tell me more about that." Right? You combine the open question with what we call a reflection statement, and that's what really builds the empathy, and that's what we really all we want. But in big emotion cases, it's the key. So that's in the difficult encounters, this is key. And we got lots of studies on this, but we don't have the time to sort of go over them. Let's just say it helps, right? So there's good data. And as a patient now, I'm now at the point with enough gray hair that I get to see that's the one thing I want. I want the person to walk into the room and sort of look me in the eye as we meet for the first time. So open questions, diagnosing what's going on emotionally, and then doing some empathy. And the key skill to that is this reflection thing, saying back what you heard. So I'm so sad. I'm really concerned about this cancer. This is really awful. What are you going to say to this person? Sort of the same thing. You can see that there's a rhythm to this. You almost do the same thing each time, right? So what would you say? I can see you're worried about this. And it's pretty reasonable. If you have breast cancer, it'd be reasonable to say, and I would be, yeah, that's scary, right? That must be scary. And then, tell me about it. Yeah. So open questions, tell me about it. But important with this is something called nonverbal. This is an ER patient with a bad cough. ER doc comes in. They know she has pneumonia. And just watch the nonverbal here. Listen to, but watch. It's a difficult patient.
Can you get a nurse to disconnect my IV, or I can do it myself?
Why do you want to go? It sounds like you're pretty sick.
I don't need to stay in the hospital for a simple pneumonia. Is my brother out there? He can take me home.
I think your brother's giving insurance information. So you don't think you need to be in the hospital?
That's right. Look, can I just have some oral antibiotics?
That's enough.
So I told her to say reflective listening, so she did a reflection listening statement. How's it working? Something's missing. What do you think's missing? Standing behind the patient? Is that a problem? You got a problem with that? Yeah, right. So standing behind isn't good. Eye contact isn't there. So if you don't, so what happens is, empathy is an emotion, so your nonverbal and your verbal need to match. Oh yeah, does that mean anything? So interestingly, this stuff's contextual. So it could mean I'm cold, which I certainly was this morning when I took a walk. I thought Denver was cold. You guys have it. There was a wind this morning. So it's contextual. But yeah, so she's looking down. She's behind the patient. She's crossing her arms. So even though she says good words, and she really does a wonderful job in this is a long interview. She does a great job with a tough patient. It doesn't work because the nonverbal is not. And so your nonverbal and your words need to be congruent. And then, by the way, how long does it take someone to decide if they like you? 5 seconds? Yeah. Okay. Mrs. Jones, how you doing? I'm Dr. Boyle. I'll be your rheumatologist today. How are you doing?
I'm having a lot of pain in my knees.
So how long, what did I do in my introduction? Did I turn the computer on? No, I didn't swipe the computer. Okay, what else did I do?
Both hands.
Yeah, so there's a couple things in the handshake. I did a handshake like this, and I actually rolled it a little bit this way. What's that mean? Non-verbally. I mean, she's in charge. As opposed to me saying, It's hard to tower over her but doing this, which means I'm in charge, right? So doing this, I did sort of the minister thing. You don't have to do it that way. If that doesn't work for you, that's fine. But how long was that introduction? Does she trust me, do you think? Yeah. What is it? How long does it take someone to decide if they like you? It's actually like 2 seconds. So what could you possibly do in 2 seconds? I mean, it takes people about 15 seconds to realize it in the cerebral cortex, but it's a limbic system thing. It's deep in their the lizard brain where they pick this up. What is it that they notice that makes them say, I like you in 2 seconds? Facial expressions, eyes, mouth. Eye contact. I mean, that's the biggest thing is just walking in the room. And so for successful interviews, and I know we have to wash our hands and you have to have patient identifiers. I'm a doc. I got it. Got to turn the computer on. The thing doesn't start until we click in. But that when you walk in a room, that is valuable time. In my trauma buddies talk about the golden hour. Do we have a traumatologist here? Any trauma surgeons? The golden hour is the first hour, right? I think this is the golden minute. I think you have the first opening, and so don't be turning swipe the computer on to get it, geared up. But hi, how you doing? Lean in. So be thinking about how you introduce yourself in that very first. And that was what this doc, even though she does a wonderful job, she didn't do it. She wasn't, she just sort of walked in and swept by. But, come in, talk to someone, and it is about the eye contact. It's about personal connection. So what's your good nonverbal? And my good nonverbal is the same as, but let me try it. So tell me more about if you had this pneumonia, tell me about it, right? So it's not working. What should I do? Lean in a little. Cross your arms. Okay. So I actually have, this is the position, did I do it? Worked? Did I blow it? Okay. So that's my position for difficult encounters. It's really almost always like this. If it's the angry person, I might move back a little, but like my nose is not great, but I like it the way it is. So, but really sort of, it's almost like this. It's every time. And it's really both feet on the ground, sort of leaning in. Again, you don't have to do it exactly the way I do it, but think about what your nonverbal is in these situations. So in empathy, the patient needs to experience being heard and seen. And the way they do that's with those words and with that connection, right? So understand, reflect, and then comfort. So finally, this is the best business book ever written. It was written 30 years ago now, 40 years ago. And rule number 5, 7 habits. Habit number 5 is seek first to understand and then be understood. And that's what I'd like to leave you with. Seek to understand and then be understood. So when you're with a tough customer, things aren't quite going right, tell me about what's happening. We have a risk manager here. So what are you really upset about? Tell me about, you need to know what's going on. So we have our toolkit, open questions, diagnosing what's going on, empathy, nonverbal, and then really what we call discover the meaning, always trying to understand why is this person, I understand why someone's upset with a new diagnosis of breast cancer. I can get that right away. But the MS lady, I'm not so sure why she thinks she has MS. The knee guy, I didn't know right away what was going on. So tell me about what's happening. Tell me understand that. So, all right. So doing something over and over doesn't mean you're perfect. That's the Anders Ericsson, and now Malcolm Gladwell has this. So what are you going to do different because of this talk? So you need to do one thing at a time. What are you going to try different because of this talk? One thing.
Listen and be aware of my own emotions.
Listen, and what was the second part? Be aware of, yes, your own. That's a whole nother discussion of how that affects what you do. How about, retinologist, you do?
Make sure I don't look at the computer until I look at the patient.
Look at the patient first. Oh, gosh, that's wonderful. So how about you? What are you going to try different? Listen and more empathy. All right. Anyone? What are you going to try? Anyone? Yeah, listen before you swipe in. So the way this works is I threw a lot of stuff out. You're not going to do all that this afternoon, but if you just when you're seeing that angry patient, that's the tough one for you. What are you going to try? I'm going to just think about the next time you see that angry person. What are you going to say? So tell me about what's going on. What are you really upset about? So just have that in your toolkit, because it's very hard when someone's like this and staring like that. It's nice to have in the back of your brain, what are you going to say without having to conjure it up, but to really say, and you'll notice that you almost say the same thing each time. So that's sort of really the fun part. So I think our time is up. So I'll take any questions, but you guys can certainly leave if you got customers to say. We don't want to be late, so. 1 o'clock. So yes.
Do you have any recommendations for documentation, especially in light of our organization towards open notes?
So the recommendations about documentation, but what was the specific part?
Do you have any recommendations for documentation, especially in light of our organization moving towards open notes?
Yes, I think you have to be politically correct. So it was about open notes. I think, I think I think you can use the word sad, or I think you can use words like upset. I think that's reasonable. I might say Joe was upset today about, how his knee was doing and his pain control. And I think that's a legitimate statement that he wouldn't get mad about. So yes, I would probably not use angry, as a descriptor, but I think upset is okay. And we talked about the emotional aspect of, where that was coming from. So, yeah. Documentation is important, so we do risk management. So, but you're less likely to have to worry about that if if you've connected and stuff. Anything else?
Would you say it's better to cut time, like to spend time with your patients and look at them? Is it better to have a shorter visit and document in your office, or is it better to say, I'm going to type on the computer for a minute instead of looking in the eye? Do you have an opinion on that?
So the question was around, how to do this effectively, and the answer is the computer has triangulated us, and so there's no great answer. The way I do it is I have a shorter visit, but it's all this way. But that's also because the way I type, people sort of laugh if they watch me type a little bit. They get the giggles, and so it just, that's the way I do. So I actually do pre-chart and post-chart. But I think it's different for different people. I think it's also okay if you say, come in, connect. So you've got the rheumatoid, and as I do it, okay. So let me go ahead and get some of this stuff going here, because I do want to order that, the next entanercept dosage for you. So let me do that, and we'll get some labs and stuff. So, so I think you can do sort of part of it. Most of the docs that I've seen that I like and I've gone to don't document everything in the chart when I'm in the room. So I don't know. But you got to do it the way you got to do it. And I don't want you to go home at night and, be up till 10 o'clock typing too, which is part of the burnout that we're struggling with. So. Thanks a lot. Thanks for your time.